Part 6, we're going to dig into more errors and analysis of errors. We're going to do a root cause analysis. So root cause analysis, what really was the cause of the error? Wrong side surgery. What caused that? Did you not take a time out? Were the doctors in a hurry? What was the basic underlying cause of that error? We're going to look at investigating and categorizing the root causes that happened. We're going to look at all factors leading up to that error. And this will be conducted by the hospital's risk management department. And the results will be given to the quality improvement department. Most common root causes: inadequate communication, incorrect assessments, inadequate leadership orientation and training. And if you think about it, if those three things are pretty much at the root cause of every error. Now, in a root cause, we're going to look at who discovered the event, not the person, but what role. So it might be the PM shift nurse or the surgical nurse. How was it discovered? What happened? What was the specific adverse event? Where in the care process was the event discovered? Or where did it occur? And when did it occur? These are all bits of data needed to really fully analyze, to do a root cause analysis. So who was involved? Again, function only, not names. So it would be a surgeon and an anesthetist and surgical nurse and a scrub nurse and circulating nurse, and then post-op recovery. Who's involved? What functions are involved? We have to look at mandatory reporting. Is there sometimes there's mandatory reporting, and is that good or bad? Personally, I think mandatory reporting is good because that way everybody's treated the same way. Every mistake gets reported rather than just, well, the perception could be, well, just my mistakes get reported. All mistakes should be reported. And why? You're going to discover the most dominant reasons when more data is available. Also want to consider the severity of the event. Was the event preventable? Was there any product drugs involved? Blood, devices, medications? What about the patient age, gender, ethnicity, diagnoses, comorbidities? This all will apply to that root cause analysis. Now I talked about near misses as being mistakes that didn't quite happen. Think you're going to give a medication to a person and you take it out of the drawer and you realize, oh, wrong person. You put it back in the drawer. That's actually a near miss. Nothing happened, but it could have happened. These are errors of commission or omission that almost happened. This is an act, and the act would have harmed the patient. Do you learn from near misses? I learn from near misses all the time, and they happen to everybody. Many errors go undocumented because people are afraid to document their errors. They assume that they're going to be punished, that they'll look bad. Excuse me. We need to acknowledge errors happen. We are human. Errors happen. So we need to make a record of that. Because if I make a mistake and let's say it's a medication error, but I don't report it, and somebody else makes the same mistake a week later and reports it, well, it only happened one time. But if they'd had my report, maybe they'd have discovered that something is going wrong consistently. And now it isn't me making the mistake or the other person making the mistake. Maybe there's something in the structure or the process that we're working that led to those mistakes. But it only happens if all the data is available. We need to avoid a culture of blame, which is simply we need to stop pointing fingers and assume that we all are here for the same reason. We're all trying to have better outcomes for the patient. Some of the common care management problems: failure to monitor, observe, and act. Many hospitals have that 1 hour eyes on, where every hour somebody has to put their eyes on the patient. That's monitoring. If you don't monitor the people, things get missed. a delay in diagnosis, incorrect assessment of risk, loss of information during transfer to other healthcare staff. That's why we use the SBAR reporting format whenever we pass information, so that we always cover all the information. Failure to carry out preoperative checks, that would be that timeout. A lot of people just, I think they neglect it because it's just a common thing, we're just going to do it. You got to have that timeout, make sure that everybody's on the same page. Failure to seek help when necessary is a big one. The person who is up with two, but I'm busy and you're busy, everybody else is busy, so I'm just going to get them up by myself. Can you do it by yourself? Possibly. But what if the person falls? Using an incorrect protocol, treatment to the wrong site, wrong treatment plan are all common errors. Medication administration, it's best if you have standardized doses, dose timing, and dose scales. So an example would be on your med-surg unit, all patients get Tylenol in 325 milligram tablets, not 500s, not some with 500s, some with 325s. Everybody gets either all 325s or all 500s. Less chance of mixing up and grabbing the wrong medication. Standardized prescription writing. Now, more and more hospitals are doing where the doctors actually put their own orders into the computer, which is great. We still have to make sure that everything is happening standardized. We want to look at reducing the number of different types of equipment. One type of IV pump only, one type of IV tubing only. Those are all ways to prevent errors. Pharmaceutical software like a Pyxis type of administration, unit dosing rather than taking medication from, let's say you need to give Tylenol and it's used in a large jug and you pour out 2 Tylenol. Might want to do unit dosing where there's just 2 Tylenols in a pack. Central pharmacy should be responsible for providing all high-risk IV medications, such as insulin drips. Those should be kept at central pharmacy. And we're not going to store concentrated solutions of hazardous materials on the units anymore. It's just asking for problems. We're going to want to make sure that there's always pharmacy available for backup and support. We'd like to include the pharmacist on patient rounds, occasionally at least, so that they have an idea of what's going on. Make sure that the patients understand their own knowledge. And a very good way of doing that is do patient rounding over the patient, so that the change of shift, you go to each patient and you give your report right standing over the patient, ideally. And that keeps the patient informed on everything that's happening, and it actually makes the patient more part of their own caregiving staff. One of the major problems with errors is nursing overtime. Whenever a nurse works more than 12 hours in any 24-hour period, or 60 hours in a 7-day work week, they're at higher risk of medication or patient errors. 39% of all nursing shifts that were over 12.5 hours were associated with a 3-fold increase in making a med error. And also, they had a greater likelihood of occupational injury. How many of you work 12-hour shifts? It's pretty common. And personally, I like them, but I got to admit, those last couple hours, I was not my sharpest. Now, let's say you work an 8-hour shift and your manager comes and asks you to work a double. You're working 16 hours. It's not a good situation. That's the end of learning, part 6. Come back for the last one.